Good evening, everyone, and welcome to tonight's webinar, Relationships and Families. My name is Brian Thompson. I'm the Programs Manager for Can Do MS. My pleasure to turn things over to Megan Weigel, who's a nurse practitioner, as well as Roz Kalb, who's a psychologist that have been at all of our webinars for this young adult series, and it's a pleasure to have them this evening. And I'm going to turn things over to Megan and Roz.
Thanks, Brian. Hi, everybody. I'm glad to have you on tonight. My name is Megan Weigel, and I'm a nurse practitioner at a general neurology practice in Jacksonville Beach, Florida, and I've been taking care of people living with MS for 18 years. I just love to have the opportunity to share with you guys opportunities to help improve your quality of life and answer your questions, and I'm excited to be here tonight with Roz.
And I'm Roz Kalb, and I'm equally excited to be here with Megan. This is our first time together. I'm thrilled to be here with all of you for the third in this series. So I trust that I've talked to some of you before, but for the people who are new to this series, welcome. I'm a psychologist in Maine, and I've worked in MS for close to 40 years.
For a sec, Roz, absolutely. So our learning objectives tonight are pretty varied. We are going to learn how MS can affect sexual intimacy and some strategies to manage those changes, as well as talk about pregnancy, childbirth, and family planning. In addition, things to consider when you're starting a family. We'll talk about how MS symptoms and progression can affect relationship dynamics, romantic relationship dynamics. We'll learn some tips for communicating effectively, and also consider how MS might impact your romantic relationships. So Roz, can you start by talking about how MS may affect relationships?
Sure. So I think I want to start first by talking about what healthy relationships involve, and they're actually pretty complicated, right? First and foremost, we at Can Do MS think that effective communication is really key. I haven't seen those ladybugs before. Those are really cute. Effective communication is key, and we're going to come back to it later. But people need to be able to talk as well as listen to each other. They need to be able to recognize when they agree, but also acknowledge differences and figure out how they're going to deal with those differences. And in order to be able to do all that, it's important that partners respect one another, have trust that their partner has the well-being of their loved one and the well-being of the relationship at heart. We need to trust that we are safe with those that we love. People need to be able to talk through their shared goals and expectations, and when they have different goals and expectations, they need to be able to acknowledge that and see what to do to bring their goals and expectations more in alignment. They need to be concerned for one another, for each other's well-being, wellness, happiness, and of course, intimacy of all kinds, whether it's a romantic relationship or a friendship. Intimacy, that trusting closeness is critically important. So we're looking to help people build all of those. When MS comes along, I think for many couples, it feels like it's catching people off guard. It's changing what they think of as the rules or their expectations about what the relationship would mean to them. So a person with MS might have this feeling, I don't feel like myself anymore. I feel like I am different. I don't know what to do about that. Partners often say, this isn't what it was supposed to be. This isn't exactly what we signed up for. How do we rechart our course given what's happened? For some partners, they feel this isn't the person that they married, and this is particularly true when mood changes or cognitive changes affect interactions in such a way that it starts to feel like you're interacting with someone you don't know quite as well as the other person. The partnership may be changing because roles shift in order to accommodate symptoms of MS. And certainly people talk about how overwhelming this all can feel. In addition to these feelings, I think that there are particular stresses and strains on the relationship itself. And in all the time I've been in MS, I've really talked about MS as being like an uninvited guest. Somebody shows up at your house and stays forever, spreads its junk all over the house and doesn't go home. So it's a little bit like having an ever-present third wheel or a stranger on a date. There's something else there that you have to take into account all the time. We know that MS is a very unpredictable disease. It's sort of the hallmark of multiple sclerosis. And so it introduces unpredictability into the relationship. What can we count on from each other and from others around us? What can we count on today and tomorrow and into the future in terms of how MS is going to impact our lives? A chronic illness like MS is also a big strain on resources. And typically, when people think of resources, they think about money. And we know that MS can be an incredibly expensive disease. But when I talk about it, it's not just money. It's a drain on time because things take longer. And it's a drain on energy, both the person who has MS-related fatigue and also support partners who may be taking on more and more responsibilities. So time and energy are critically valuable resources in a family, and they are strained. Role changes happen when people need to shift what they're doing, and sometimes that's a shift that isn't anticipated, or it isn't comfortable, or it doesn't fit life choices. And so couples need to be able to negotiate how to handle those role changes so that their partnership continues to feel balanced, to feel comfortable for both of them, and sustaining for both of them. And I think that MS can also create barriers to communication. And as I said, we're gonna talk more in a little while about communication and how to manage that in your relationship. So Megan, can you focus in a little bit more on how MS specifically affects intimacy?
Absolutely. So you hit on a key point there, Roz, with how it can change relationship patterns through changing the ability or even the desire for people to communicate, shaking up the partnership a little bit. And perhaps even more complicated is that we get to categorize what type of sexual dysfunction is happening. And so we speak about it in the medical and nursing team as either primary, secondary, or tertiary dysfunction. And it's just not that easy because as we go along tonight, you guys will see that oftentimes these things overlap one another. But in general, primary sexual dysfunction results from a change directly that occurs from, say, an MS plaque or a lesion in the central nervous system. So this would be, say, a spinal cord lesion that impairs your sensation. Secondary dysfunction is a change that results from other MS symptoms or medications. So a good example would be fatigue. And then tertiary dysfunction are changes that result from feelings or attitudes or beliefs that get in the way. And we'll talk about that a little bit more as the conversation goes on. To speak more about primary sexual dysfunction, in men, what's reported is decreased libido or decreased sexual drive or sexual desire, inability to achieve or maintain erections, decreased or altered sensation in various parts of the body that are seen as sensual and that evoke a sexual response, decreased intensity or frequency of orgasms and problems with ejaculation. And then primary sexual dysfunction in women can be similar things. So again, decreased libido, decreased interest or arousal, decreased vaginal lubrication and engorgement, decreased vaginal muscle tone, sensory changes in the vaginal area and other areas that are sensual, and then decreased intensity, frequency, or loss of orgasm. Secondary dysfunction are are changes that are a result of, say, symptoms that you have of MS. So you may be fatigued and too tired to even consider having sexual relations or intimate relations with your partner. You may have spasticity that makes intimate relations painful because certain positions are painful, or holding positions for a long time are painful. You may have pain, and that pain may be nerve pain, like the burning, tingling type of pain, or it may be joint pain or muscle pain that you have from the way you walk or how you've been in position for most of the day. Bladder and bowel problems can cause a lot of sexual issues, namely because they can cause discomfort, also because they can cause the mind to worry. Even if you're not currently having a problem, you might be afraid of, oh my gosh, what if this happens when we're in the middle of being hot and heavy, and what would I ever do? And then mood and cognitive changes. The other problem about MS is that we love to prescribe you medications that decrease your sex drive response. So medications for depression, medications for pain, medications for spasticity, anticholinergic medications, which are things for mood, pain, and bowel or bladder function, and narcotics can actually decrease your sex drive and your sexual response. Sometimes, we can use those in a good way. So we can say, well, if you take your muscle relaxer about an hour before you plan for sexual activity, then it could be helpful. Or of course, if you have a problem with depression that's affecting your sex drive, then an antidepressant may improve that. But in general, we tend to burden people who live with MS with medications that can make it even more difficult for them to have an enjoyable sexual relationship with their partner. So Roz, could you tell us a bit about tertiary sexual dysfunction?
Sure. So if all of those issues that Megan listed weren't enough, I think that the tertiary issues are in some ways even more complicated. There is no magic pill for feelings and attitudes that can get in our way. So we live in a culture that really emphasizes youth, health, wellness, thinness, all the things that you see in advertisements all the time. We are bombarded with those messages. So I think for many people diagnosed with a chronic illness like MS, one of their fears or concerns is coming from those messages. How can a disabled person be sexually attractive? Which of course they can be, but the fear is that the disability will get in the way of others seeing them as attractive. Or people will say, well, if I don't like myself or my body anymore, how can I expect somebody else to? And again, that same issue about this isn't the same person I'm married, now I have to worry about whether I'm going to hurt this person or whether this position works, or all the spontaneity seems to, be affected by MS symptoms. People who are providing hands-on caregiving sometimes struggle with those two roles and how to somehow merge the roles of a loving hands-on caregiver and a sexual partner. And as Megan alluded to with fatigue and then all those other symptoms she mentioned, lots of people just feel overwhelmed. There's just too much going on. So how can sex even rise to the top when we're dealing with so many other challenges? And I mentioned the spontaneity. Clearly, things may take more planning, so that you have to learn how to provide spontaneity in different ways. So let's talk a little bit more about treatment. So back to you, Megan, because you all need to hear the good news as well as all of the problems.
Yeah, so the good news is that there are some effective treatments for sexual dysfunction. In men, we can give you medications like Viagra, Levitra, Cialis that help improve the effectiveness and the duration of an erection. We can give you vasodilators, which are medications that dilate the blood vessels in the penis so that it stays erect. These are usually given by injection. There are penile prostheses that can facilitate an erection. There's a vacuum pump that also does that. And then, coming more in line with just, I think, being realistic with your partner and ensuring that that pathway of communication is open, because without it, none of this is going to work. Are things like body mapping exercises, which helps you and your partner, find out new ways to touch one another that may be pleasurable and enjoyable, that aren't the things that you would normally think about. And there are some good resources for those. And massage is another technique. Also, we'll talk about this for women as well, but pelvic floor exercises can be really helpful to help tune up bowel and bladder dysfunctional issues, and in turn often improve sexual issues and confidence surrounding your worries about bowel and bladder dysfunction in regards to sexual timing.
Hey, Megan, who does the pelvic floor exercises?
Yeah, so pelvic floor exercises, pelvic floor rehab is done by physical therapists that are specially trained just in those techniques. So if you're interested in that, men and women alike should ask their medical provider for a referral to pelvic floor rehab. Thanks. And then treatment for primary sexual dysfunction in women, there's a medication that was approved, I think it was a couple of years ago, called flibanserin, if I'm pronouncing it correctly, ADI, and it is a medication that helps with sexual desire, so not with ability or strength of orgasm, but primarily with sexual desire. There are a couple of other antidepressants that may do that more than others, one of them being bupropion. And then there are techniques to improve comfort and also increase arousal in women, such as water-soluble lubricants. We say water-soluble because they don't break down barrier contraception like condoms or diaphragms. Medications for nerve pain. So if you have a lot of nerve pain or spasticity, then sometimes giving you medication with appropriate timing, kind of like the men have to take their Viagra or their Cialis within an appropriate amount of time before sexual activity. Medications for pain can also be timed in that regard. Using extra stimulation like vibrators or oral or manual stimulation can be helpful. Again, the body mapping exercises and then pelvic floor rehab is very helpful for women suffering from sexual dysfunction. And then other treatments get into really helping more of the secondary issues associated with sexual dysfunction, like symptom management. So if you are worried about bladder incontinence prior to a sexual encounter, can you empty your bladder prior to that encounter to make it more enjoyable for you and have less worry? So really just about how can we manage things that are predictable to make for a more enjoyable and confident experience for you. Talked about scheduling medication. That doesn't just include medication that affects your symptoms that may improve your sexual function, but also those that may make it worse. So you don't want to take a sedating medication 45 minutes before your boyfriend or your girlfriend comes home and you want to be intimate because you'd be asleep, right? So, so medication timing is important. And then being creative and flexible with positioning, with techniques, with pillows, and there are all kinds of ways that you can get creative with sexual encounters when you're dealing with issues that are related to mobility and pain. The tertiary treatments for sexual dysfunction as a nurse and as a nurse practitioner are often the ones that I find to be the most rewarding. And perhaps as we go on, we'll talk more about those. But those are things like just education about our bodies and about the importance of relationships, about the importance of communication, counseling, and support. And you know, one of the issues that comes up when we're dealing with sexual function is something that could have happened in your past years ago that has nothing to do with MS, but maybe affecting your ability to be intimate. And so counseling can help you through these things so that you can have an enjoyable relationship with your partner as you move forward, which brings us to, you know, the whole dating experience when you have multiple sclerosis. We get a lot of questions about that. And Roz, maybe you can tell us a little bit more about how you step into dating when you have multiple sclerosis.
And I just want to say, based on the age ranges that we saw in our very first polling question, we're not just talking about dating early on, but dating at any point in your life when you are looking for a partner, no matter what age you are. So I think one of the most important aspects of this, you know, is what's going on in your own head. That for you, MS may feel like it's just taken over your life or that it's overwhelming, but it's really important to hold on to the fact that MS is part of life, but not all of it. And it's part of who you are, but it's not all of who you are. And so letting all those interesting, attractive parts of you show to others is part of meeting new people and engaging with them. For anybody, no matter how old we are, first dates don't require show and tell. I know they frequently involve show and tell for many first relationships, but they don't have to. And particularly if you're meeting somebody online or you're meeting somebody for the first time at some social event, you can make a decision about whether this is a person you want to spend any more time with before you decide how much of your information you want to share. So that may not just be the fact that you have MS, but other things about yourself that you might hold back until you've made the determination that this is a relationship that you think you might want to pursue. Once you've decided that a relationship is worth pursuing, that it's worth your energy and your time and your emotions, then it's worth sharing this critical information about yourself, just like it's time to share other important information about yourself. This is when you talk about yourself, and it's also when you're going to learn about the other person. So most people will say to me that they're astounded that when they share information about MS, they learn all kinds of things about the other person, because chances are the other person has some things going on as well, particularly as we get older and we're meeting people for the first time. Almost everybody has been touched by some health issue or other life challenge. And I think one of the best, rules of thumb is to tell at that point in a relationship when you would want to know important information about the other person. That's really your green light. I like this person. I'm interested in pursuing this. I really want to know what makes him or her tick. I want to know all the bells and whistles and warts, and so I'm going to share mine. And I think it's also important that telling each other things honestly is the beginning foundation of a good relationship, of the kind of intimacy that we've been talking about. Holding back on the truth doesn't really help lay that solid foundation. The other thing, whether we like it or not, is that the risk of disclosing is easier. It doesn't get easier as time goes on. It's easier at the beginning before you've invested heart and soul. So it's probably easier to put yourself on the line a little bit earlier on. And the fact of the matter is, and again, I've been doing this for many, many years now, what I have found is that yes, some people you meet may be frightened off by MS. They'll be less frightened if you're able to put your teaching hat on and fill them in on information about MS and share your story, and let them know that your MS may not be like their Aunt Matilda's or their Uncle John's. It's your MS. And other people will not be frightened of at all. I've seen many really good, solid relationships happen for people, so I encourage you to jump in. So now I think we're going to introduce our first vignette for tonight. We're going to talk about Joaquin. He is a 26-year-old graduate student who was diagnosed just a year ago. He has not told any friends yet about his MS. He's very concerned that others' opinions of him will tank because he just doesn't want to be different from his peers or from others around him. He's got quite a few symptoms at this point. He does have some issues with erectile dysfunction and loss of sensation. He has some stiffness in his lower limbs, his legs, and his mood has been off, and he's having more trouble concentrating and remembering things. He has been on a few dates with Sophia, his classmate, and they're hitting it off. And he's pretty sure that Sophia wants him to move things ahead, to take the next step, but he's convinced himself that she's going to reject him when she finds out about MS. So as he's doing all this brain talk to himself, talking him out of this, he's really starting to feel like he's never going to have a serious relationship. What would you like to do for Joaquin first?
So I think that's an encouraging result, because we all know that we need support, and if we don't have it from outside sources, then we don't have anyone to back up what we might be saying. So suggestions for Joaquin at this point, they really span the gamut of what I talked about earlier. Because of his physical symptoms, I think he'd do well with some rehab therapy. So physical therapy to help with the spasticity in his legs and help him to develop an exercise program that makes him feel stronger, rather than gives him concern about what's going to happen to me. And then to address the pelvic floor issues as well. And then we can give him medications to improve some of his symptoms, like the spasticity, but we need to be careful of side effects because most muscle relaxers can cause sleepiness. They can also decrease the ability to have or maintain an erection. But we could give him a treatment for erectile dysfunction, such as one of the medications like Viagra or Cialis or Levitra. And then, of course, you have to throw this in there because we're talking about sexually active people, and we need to remember that MS doesn't protect you from having other issues such as sexually transmitted diseases and babies. So it's really important that we talk to Joaquin about those things so that they're on his radar as well. But Roz, I think one of the biggest pieces of this picture that could potentially even avoid the need for any medication would be to employ our psychology colleagues, our counseling colleagues. This is where you and I work so well together, because we would be, assessing mood, assessing depression. And so if you could tell us a little bit more about how that would happen in your court.
So what I'm hoping is that if Joaquin shares this information with his nurse or his neurologist or his friends or Sophia, that they suggest he talk to a mental health professional, because the very first thing I would want to do is evaluate Joaquin's mood. We know that depression is very common in people with MS, even newly diagnosed people. It's part of the disease itself, and so it is very possible that he could be depressed or even significantly grieving over these recent changes in his life. And those mood changes can affect many of the issues that he's having, certainly his self-confidence, his erectile issues, all perhaps might get better simply if his mood was better. So that is the first thing that I would want to do. And if he is experiencing depression, I would want to help him with that. And then talk therapy can really not just help with mood, but his loss of confidence, the grieving that he might be doing. That's a process. It's a normal, healthy process he needs to go through, and he may just need to do some talking about that before he can get his confidence back. And if he's worried about communicating with Sophia or anybody else in his life, I think we can talk about communication skills. So, Megan, can you introduce us to Carol and Judy?
Absolutely. So Carol and Judy are high school sweethearts. They've been together for about 8 years. They were very affectionate and physically intimate early on in their relationship. But since Carol was diagnosed with MS 4 years ago, her sexual libido is all but gone. So her desire to have sex just isn't there, to be intimate just isn't there. She's experienced more physical symptoms of sexual dysfunction, such as vaginal dryness and the inability to have an orgasm. She's also working more hours at a busy law office, so she's just too tired, and probably too tired to even think about the fact that there might be a solution. They actually haven't been intimate in over a year. Judy, who is a doer rather than a talker, thinks it's her fault, but she's unsure how to fix the relationship, and she's kind of scrambling and doesn't know what to do. In spite of all this, they haven't discussed their concerns with each other. They're just trying to get through each day and make it. Well, again, this is where we need to pay a lot of attention of our ability to work together as a team here. But as from a nursing standpoint, a conversation with the MS nurse in their practice would be very helpful to discuss the physical symptoms associated with sexual dysfunction, like the vaginal dryness, anorgasmia, loss of libido. And I'd add in here, again, because of the age group in attendance, that it may not just be multiple sclerosis that's causing problems. So if you're a woman of menopausal age, some of these things may need to be addressed by a referral to a gynecologist to look at hormone levels. A nurse can also help with fatigue, as can an occupational therapist, to help Carol try to figure out how to manage her busy life in the best way to conserve her energy. And then a review of those medications. Are there things that she's taking that could be hindering her sexual desire or performance? And might we be able to change some of those? But gosh, Roz, I mean, it's just, to me, I'm in complete agreement with our audience that communication may be the biggest issue here. So can you talk to us a little bit more about that?
Sure. So my starting point again would be to just see how Carol is doing emotionally and rule out depression. They're both dealing with a lot of stress and how to manage their time together and their time at work. So they may, in fact, benefit from some couples counseling. But I might also suggest that Judy have some time on her own with a therapist just to talk about this major change in her life as well as in the relationship, just to make sure that everybody feels comfortable sharing thoughts, worries, feelings, concerns. Because they, as was mentioned, they do have different coping strategies and they have different communication styles. So we would actually need to help these two women learn how to communicate in ways that were more comfortable for both of them, both the talker and the doer. So if we look at communication, and you know, we could spend an entire evening on this, but we can go to the next slide, please. You know, we talk about communication a lot. It's a real buzzword. And in fact, at one of our Can Do programs a few years ago, somebody suggested politely from the audience, you guys talk a lot about communication. Could you please tell us how to do it? And since then, it's been a key component of our programs. But if you think about communication, we're trying to do a lot of things when we communicate with another person. I, as the speaker, am trying to convey my thoughts, my feelings, my needs. And I'm trying to do that while I'm also respecting the ideas and feelings and needs of the other person. So just those things alone are challenging. We also want to send clear, unambiguous messages. We often give mixed signals, even when we don't mean to, and then we're upset when the person can't read them. We want to invite a response rather than setting up a conversation in a way that really scares the other person off from responding. So how do we talk in a way that encourages a response? And then we need to allow time and space for the other person to think about it and respond, particularly when we're dealing with some cognitive issues or aging issues. It may take the other person some time to respond, and we need to be respectful of that. So this is pretty complicated, but in our very busy lives, we have a lot of very significant barriers to this kind of communication. Many couples will say there just isn't time in a day. There's just no break from the kids or the job or the whatever to have good, clear communications. People struggle to put complex feelings and thoughts into words. We often don't want to upset our partner who's already stressed out or worried about something, so we may not say something rather than say something that might be upsetting. Some of the topics we've talked about tonight are embarrassing. It's just hard to talk about some of these intimate issues, and some issues are just painful. The loss is very great, sometimes related to MS, and so those losses are painful and people don't want to spend time talking about them. Cognitive changes, as I mentioned, can slow the process of communication, can make it very hard for the person with MS to put their thoughts together and form a response, and meantime the partner may be getting impatient or frustrated or wonder what's going on. And mood changes like depression and anxiety can create huge hurdles, because when you're depressed, it feels like it takes an inordinate amount of energy to communicate and to put your thoughts into place. And when you're very depressed, you just may not even care. And I'm sure there are others that we could come up with. So I just want to give you a few tips. And I'm going to start by saying that good communication starts with listening. Most of us start it with talking, but it starts with listening. And you want to listen actively. You want to focus, pay attention, confirm what you've heard and that you've heard what the person is actually trying to say. Pay attention to your body language. If you're rolling your eyes or looking at your phone or watching television, you are not paying attention. And in fact, you're conveying kind of disregard for what the other person is saying. If the other person says something that hurts you, hurts your feelings, causes you pain, I think it's very appropriate to use a shorthand signal like, ouch. That gives the other person a chance to rethink what they said or apologize if it came out in a way they didn't mean it to. But everybody understands what the word ouch means, and it's a good signal that some more talking needs to happen. Try not to interrupt, even if your partner is slow coming through with comments or responses. And please try not to jump to conclusions. If you're not sure what a person is feeling or thinking, it's important to ask. Don't finish their sentences for them. Don't assume you know. Confirm what you've heard, and if it's not on target, ask. And when you're talking, it's important to make time for talking. We make time for lots of things in our lives: television, exercise, work, eating. Talking is just as important. So it's really worth the effort to figure out a time for it. If you have very different styles, like Judy and Carol, it's important to acknowledge that and respect the other person's style. If you use I statements, I feel this, I think that, I wish that, you have much less risk of putting another person on the defensive. You're not accusing them of anything. You're not pushing them into a corner. You're simply stating your feeling, your wish, your thought, and then give the other person time to think and respond. Be careful not to overgeneralize. When we say you always or you never, we are making accusatory statements that don't give the other person any wiggle room. So they are likely to claim up. So don't overgeneralize. Try not to use too much sarcasm because that's a turnoff for most people and it feels hostile and angry. And try not to engage in magical thinking. So this is really important for people who are close. Our fantasy is that another person who loves us very much can read our minds. They should know when we're tired. They should know when we need help. They should know when we're feeling great and don't want help. But the fact of the matter is that nobody can read our minds. So rather than putting your partner on the spot by expecting that, be clear about when you need help and when you don't. Be clear about what you're feeling or not feeling, so that the conversation can move ahead without the other person having to guess. So now we have a little segue here. It's quite little. But Megan, can you just talk to us a little bit about what we know about pregnancy and childbirth and MS?
Yes, absolutely. So pregnancy and MS can occur even without communication, good communication skills. So it's really important to consider the things that we discussed earlier today when you are looking forward to planning a family. So there's really great news about fertility in MS. Your fertility is not affected by MS. So again, don't forget the birth control if you're not ready, and that includes men living with MS as well. Pregnancy hormones actually suppress the immune system's abnormal response. So in general, people living with MS feel very well when they're pregnant. Sometimes their symptoms actually decrease in severity when they're pregnant. And relapse rates drop significantly during pregnancy. The risk of relapse does rise in the 6 months following delivery. But the good news is we know that in general, how you do after pregnancy is directly related to how you were doing before pregnancy. So if your MS is well managed and you're not having changes in your disability level, you're not having relapses, your MRI is quiet, then you're much more likely to be that way after pregnancy as well. But childbirth isn't a walk in the park for anyone, but moms with MS can do it just fine. So many times people with MS, depending on their age, will be referred to a high-risk OB. And from a neurological standpoint, there may not be any logical reason for that, except that that's what our OBGYN colleagues like to do. It doesn't mean that you are at risk for an adverse event any way more than the next woman who's having a child. Parents with MS have healthy babies. They raise healthy children. Breastfeeding is definitely an option, and that's something that you should have a good conversation with your neurologist or your MS provider before you have your baby. I think it's really important to have a post-birth plan. And if breastfeeding is very important to you, then have a discussion with your provider about what that might look like for you, what a safe period of time for breastfeeding might be. Because exclusive breastfeeding may decrease your risk of postpartum relapse, but that has to be taken into consideration with what your MS was doing before you got pregnant, and then what it's doing in that first 3 to 6 months after you have your baby. But it's really an important thing to talk about before you actually have your child. I'm a new mom, so there's a lot of emotion wrapped around breastfeeding, and I think trying to address that before it is a reality is important. Pregnancies do not increase the risk of long-term disability with MS. So, in general, just if you're a woman living with MS and you want to have a family, we encourage you to do it. There's no reason why you shouldn't if you can handle taking care of a child. There are things to keep in mind when you're family planning. And one of the most important of those things, we can go to the next slide, please, is considering the genetics involved. And actually, I think this is fairly good news too. So children who have a parent with MS have a slightly higher risk of developing MS, about a 3 to 5% higher risk, which actually is not that much higher. So I have people ask me in my office all the time if they should not have children because of this disease, because what if their children have it? And as you can see, 3 to 5% is a pretty low risk for passing something on to your child. Now, if both parents have MS, there is a significantly higher risk, and that might be a different conversation to have, and certainly one that takes into account the long-term responsibilities of parents and what their goals and desires are for having a child. There is not a test or genetic study available to determine your child's exact risk, nor would we ever recommend screening a child for multiple sclerosis because one of their parents has MS. The best thing that you can do is if you do decide to have children, ensure that they maintain healthy vitamin D levels through childhood and their teen years, because this may reduce the risk of developing MS. That means encourage your children to play outside, talk to their pediatrician about checking a vitamin D level if they think that that's appropriate, and talking to a pediatrician about what the appropriate dose of vitamin D is to give a child at different ages, because it varies. Also, not smoking as a parent, and encouraging your children not to smoke also reduces the risk of developing MS. I can't stress enough that even secondhand smoke increases the risk of developing MS. So if it's not enough to quit smoking because you're trying to get pregnant, that should be plenty. But if that's not enough, then, or if it's a partner that's smoking, then it's very important that they try to stop. We'll go on to the next slide. There are certainly other things to keep in mind when making your family planning decisions. And one of those is timing of pregnancy and disease-modifying therapy. So if you are using a disease-modifying therapy for your form of MS, none of them are approved for use during pregnancy or breastfeeding, but your doctor may have some experience or more up-to-date information about how your disease-modifying therapy should be timed. And really, I can't stress the importance of coming up with a plan. Pregnancy is not always planned, but certainly if you have a good calendar of when you might perceive this happening in your life, then you can have a plan for creating optimal disease management of your MS, and then stopping your disease-modifying therapy in an appropriate time to get pregnant safely, and really discussing this with your partner and your healthcare providers. Women and men should discuss this before they stop birth control. You just don't want to put yourself in another unpredictable situation. MS is unpredictable enough. And so this is an exciting thing. Surgery, you're planning for perhaps one of the coolest things you've ever done in your life. So I think it's a nice thing to talk to your doctor about. There are some other behavioral things that go into planning a family too, though, Roz, and perhaps you could key us into some of those.
So I'm going to do this quickly so we can get to our last vignette, but I think it's just important when you're doing this planning that Megan is talking about to remember that babies grow up fast. People tend to focus on when they first bring that baby home from the hospital, will they be able to take care of this newborn? But as Megan can attest, they grow quickly and they're soon moving around, busily bustling toddlers and then young children. So think about the unpredictable future, take a look at your support network, and most important, talk about your teamwork. Are you a couple that can be adaptable, creative, flexible when you need to be, to do the kind of effective parenting that you want to do? And just keep in mind that effective parenting is about providing love, security, and a safe place to grow. It's not whether you can run fast or jump high. So Megan, can you introduce us to our last vignette?
Absolutely. So our last vignette is a couple named Brian and Sara. They've been living together for 5 years and they're thinking about getting married and having children. They're both in their mid-30s and they figure it's time. Sara, who has active relapsing MS, is experiencing more fatigue, issues with bowel and bladder function, and anxiety. And so she worries about, what she can expect in the future. She wants to have a family before it's too late, but she's concerned about stopping her DMT for her relapsing MS. Brian is just scared to death. He's worried about family finances, and he really is focused on Sara's health and wellness. Can't imagine bringing anything else into the mix. From a nursing standpoint, I would want to get more information, primarily about two things. One would be about the state of Sara's MS and her medications. Is she stable? Has she been in a period of frequent relapses? And the other would be about her fertility given her age. And I would definitely ask that she see her OBGYN about that. So, we're adding some additional team members into their family plan. What do you think, Roz?
Well, I agree with our audience that we really need to address Brian's anxiety, and however uncomfortable it makes Sara, she needs to hear him out, and they need to work together to figure out how they would address the things that he is particularly concerned about, family finances and her health and wellness. And it may be that if they have a good financial planner and they get some good advice, and he goes to the neurologist or the nurse practitioner with Sara and hears what the plan is for health and well-being, it may be that his anxiety will be taken care of. But together, they need to figure out what their priorities are as a couple, to make sure that they're aligned in their priorities, and if they're not, figure out what to do about that. They need to be able to plan together, and all of this obviously involves that communication we're talking about. And this is exactly the kind of hot topic communication that can just get very stressful. And so this is where a mental health provider can actually be quite helpful as a third person in the room, just to help them listen to each other and share their feelings and concerns in a constructive way so that they can come to some resolution. So I think we probably have some key takeaways from all of this. We covered a lot tonight. So Megan, what do you think?
Well, I think probably the foremost takeaway for me is that there's not one single cause of relationship difficulties, and that the common denominator is that communication It's critically important, not only to establish a good foundation, but also to, increase the quality of a relationship. And we can see that emotional health is directly related to physical health. In the case of Joaquin, if we address some of his emotional symptoms, then we may fix his physical symptoms without the need for any, magic pharmaceutical wand. And, people with MS can have healthy and happy relationships. There's no reason why they can't. And, in fact, those of you on the call tonight, I'd encourage you to share this with your friends who don't have MS because they probably need the information too. Roz, do you have anything else you'd like to add?
No, I think you've covered it, and I hope people take these positive takeaways home and talk about them with each other.
Yes, thank you so much for those great tips and strategies and information that hopefully our participants can use now or in the future. We do have some time for some questions, so thank you for sending those in. Keep sending those in your chat box. Roz, we'll start with you. You talked about when it's the right time to disclose to your partner, whether it's a new person you're dating or someone you've been married to for years and maybe have a family with. But can you talk a little bit about how to tell that person? I guess it would be different for everyone, but how to go about disclosing that to a partner?
It's actually a great question, and it's a very personal question because all of us have different styles. But I think it's a good idea to plan the conversation because you need to think about what it is you want the other person to understand. And you also need to think about what you're hoping for in terms of a response. So you need to put your teaching hat on, actually. You need to be able to say what you have, but the name multiple sclerosis is less important than the information about how it's affecting you, what you're doing to take care of yourself, and why you really want this other person to know. And then I think it's really helpful to say, I'm sure you have a lot of questions. You may need to think about your questions for me, but I will answer anything as best I can and get you information to help you understand what this is all about.
That's great. Thank you, Roz. Megan, you talked a lot about different symptoms. Are there differences with relapsing MS compared to progressive MS?
As far as symptoms of sexual dysfunction and emotional issues related to that go, no, there really aren't differences. I think that people living with all types of MS face different challenges as they move through diagnosis and acceptance, and then living with the disease for a period of time. I think the one that probably doesn't go away for anyone living with MS is the unpredictability and the fear of what might come next, whether or not you have any visible physical disability. So I think there's much more in common than there is not in this topic.
I agree.
That's a great point. And speaking of unpredictability, Roz, we received one question that says, my worst symptoms are increase in unpredictable anger and impulsivity, lashing out at others, short fuse, etc. Are there ways to manage it and control that so they don't take it out on their family?
It's a good question, and I think we would need to start by figuring out why this is happening. Sometimes that irritability, lashing out, and temper is a sign of depression. In fact, we have good research indicating that people with MS who are depressed sometimes present very differently from our stereotypical picture of a depressed person, staying in bed all day, not doing anything, crying a lot. Irritability can be a very prominent symptom for people who are depressed. So I would want to find out if you're depressed, We also know that irritability and significant mood changes can happen in MS apart from depression. And some of that can be managed with some talk therapy, but also I worked with a guy who had a lot of temper outbursts in odd places, and his physician prescribed a very low dose of a mood stabilizing medication, which actually helped him just feel like himself again. It didn't sedate him, it didn't change him. He just felt like the nuts and bolts were back in place, so he wasn't losing control. So it's critical here that you get a diagnosis, and that needs to come from a mental health professional who can spend some time digging for the facts. Megan, did you want to add anything to that?
No, I totally agree. I would say that if it's a sudden issue, then it would be worth determining whether or not it could be an example of a relapse. However, it would probably be much more likely not to be. So I agree.
Great, thank you. Megan, we received a couple questions about yoga and exercise, which are topics that we love here at Can Do MS. Can yoga or exercise, can that help with some of the symptoms that we have been discussing?
So yeah, and in a multifaceted way. So the small studies that we have that are about yoga and multiple sclerosis do note improvement in bowel or bladder function. They also note improvement in mood, particularly anxiety. Exercise in general is a phenomenal natural antidepressant and anti-anxiety therapy. So adding those things into your life can help improve your mood, which in turn could turn on your sex drive. They both improve fatigue. They both improve, both exercise and yoga can improve strength and balance. So I see nothing but good for them in improving your sex life and particularly your emotional health.
Absolutely.
Particularly if you do it together.
Yes.
Yeah, great activity. Roz, can you talk a little bit about adopting children and how MS can affect that?
Well, it's a great question, and I'm afraid we don't have a very clear answer. I have known over the years couples in which one person had MS who successfully adopted, and I have known other couples who were not as successful. So I think there isn't a clear answer either way. It's something that you just need to explore in your local area and consider all different kinds of adoptions, whether it's newborns or older children or special needs children. So I think I would just encourage you to do some exploring and see what you find out. No promises.
Different local areas. Megan, how can someone deal with leg spasticity while having sex?
So a couple of ways. Let's talk about it first from a preventive strategy. I think the first place to start would be asking for a referral to a physical therapist to talk about exercises and stretches that can help with spasticity. And then second is like in the moment. So it's important to make sure that you're well hydrated, because being dehydrated can increase spasticity. Having a full bladder or being constipated can increase spasticity. So timing toileting around sexual activity will help eliminate spasticity or help decrease it. Taking muscle relaxers within, say, 60 minutes of sexual activity can help with decreasing spasm, presuming that they don't make you too sleepy to enjoy the experience. And then also positioning. So pillows, there are actually like triangle pillows that you can buy. Working with your partner, again, here communication is so key because you may need help to get in a certain position or remain in that position so that you have less discomfort. So I think it's important to work on it. Think of it again as a preventive strategy and then as an in the moment strategy. And it may take some time to prepare for that encounter, but I know it would be worth it.
And one other thing to think about, and this is true not just for sexual intimacy, but all aspects of your relationship, it's being willing to consider doing things differently than you've done them in the past. The more flexible you can be in your thinking and the more creative, and a little sense of humor thrown in really helps a lot. I think the people who run into the most difficulty are those who really get stuck in, well, this isn't the way it was before. And whether it's aging or MS or any other changes that come in your life, it's being open to trying new things.
Yep, that's great advice on all aspects. I think we have time for two more. Roz, we talked a lot about communication, and specifically, this writer wants to know about communicating about her fatigue. When she tries to communicate, her partner says, well, I get tired too. And she kind of feels that it's her fault that she's not explaining it well enough. Do you have 30-second armchair psychologist advice?
It's a question I've heard many times over the years. It is very hard to convey that invisible symptom to people who have never experienced it. So one bit of armchair advice is to come to an MS program, come to a can-do program, because I have heard more support partners say, God, I thought this was just Jane, or I thought this was just Fred, and here I am in a room full of people talking about this incredible fatigue. I just didn't get it until now. So sometimes they have to hear it from more than one person. And the second bit of advice is the National MS Society has some brochures just for this purpose. There's one called But You Look So Good, and it's particularly to explain to other people about those invisible symptoms of MS that they can't see and they don't understand. And there's another one about fatigue. And so reading that kind of material shows that it's not just about you, it's a symptom of MS. In fact, it's the most common symptom of MS.
Excellent, thank you. And then lastly, we have a question from a mom. We do have quite a few parents on the webinar, and the mom is concerned that their child's physical and cognitive symptoms are going to get worse, and wants to know how she can be supportive without being too overprotective about their child's family planning.
So this is a mother of a person living with MS.
Yes.
Okay. So, I think it's hard for parents to grow up with their children with their MS, particularly depending on when the person was diagnosed. But here again, communication is key. And Roz, I'd look to you for a little bit more advice about this, but I think it's important for a parent and an adult child when talking about family planning for at least both of them to understand each other's concerns. So the parent is obviously concerned for the child who's an adult, and the adult is concerned for her relationship and may have some boundaries put up there to the parent because they're no longer a child. So I think it's just important to ask a lot of questions, not to push a lot of opinion, and to offer support. Roz?
So I would just offer that that's true about most things our adult children do, with or without MS or related or not to family planning, that as parents we sort of walk a fine line between offering support and giving too much advice. I do think that the information Megan shared tonight about MS and pregnancy is very reassuring, and I would make sure to review that information again. Again, the National MS Society has lots of good resources about pregnancy, including a video called Kara's Story, which takes a woman through her pregnancy and delivery with MS. And so as a parent, I think you can be quite reassured that the data are very, very positive, and that we have many, many young women and men starting families, raising families, even though they have MS.